Good morning. Welcome to our first grand rounds of the new year. And it is really my great pleasure to have Dr. Hagen, Jennifer Hagen, back visiting us. We planned this at the Academy last year, so I've been anticipating it for quite a while. Dr. Hagen attended medical school at Case Western Reserve University in Cleveland, and then joined us for her fellowship. After residency, she did an orthopedic trauma fellowship at University of Maryland Shock Trauma, and that was followed by an AO research fellowship in Davos. While she was a resident here, Dr. Hagen was awarded the Medical Staff Teamwork, Leadership, and Caring Award in 2010. Jen then joined the University of Florida Department of Orthopaedics and Sports Rehabilitation in 2015. She was Teacher of the Year in 2016, and then in 2018 she was appointed both the Chief of the Trauma Division at University of Florida and then also the Director of the Trauma Fellowship. She also was instrumental in University of Florida gaining level 1 trauma certification in 2019. Dr. Hagen has not neglected her academic work. She has a grant funded for the APREP open fracture study that's funded by the DoD and PCORI. She actively collaborates with the Department of Biomedical Engineering at University of Florida and has an R21 grant to study the osteogenic capabilities of human placental matrix. And I would just add to the bio that we would have known all of this would come to fruition while Jen was a resident here. She was just a fantastic surgeon, fantastic resident, a great colleague, and really is a role model for all of us. So I'm really excited for her early success and happy to have her back. And this morning, she and Dr. Sara Shin are going to be talking about mangled extremities and management of bone loss.
All right. Good morning, everyone. My name is Sara Shin. Dr. Hagen and I will be discussing mangled extremities and management of bone loss this morning. Just to start off, we're going to have a brief discussion about the epidemiology, move on to emergent management, and then delve into decision-making process of whether we pursue a salvage procedure or amputation with these patients. We're then going to discuss definitive management and then some techniques for dealing with bone loss. So first, the mangled extremity, it's important to keep in mind this is characterized by a very high energy trauma that involves not only bony injury, but significant soft tissue injury as well, as long as with potential vascular damage. The mangled extremity is really becoming a significantly more prevalent issue in orthopedics, especially over the last 20 years. Some of this is due to significant auto safety improvements over the last couple decades. The number of fatalities per 100 million miles driven has dropped from 1.73 in '94 to 1.08 in 2014. You can see in this photo comparing two similar make cars in 1997 and 2017 crashing 40 miles per hour into a concrete barrier, that a lot more people are walking away from car accidents that they weren't walking away from 20 years ago. And because of that, we're seeing a significantly higher number of mangled extremities actually show up in the hospital. We've also seen a significant increase in field response times. This study done in North Carolina evaluated response time effectiveness and found that field response times of emergency medical services less than 5 minutes were significantly associated with improved survival rates. Mortality risk was 1.58% for patients whose response time exceeded 5 minutes, and it dropped to 0.51 for those whose response time was under 5 minutes. Applying that here to Seattle, Seattle's Medic 1 average response for basic life support is 4 minutes and 40 seconds. So here at Harborview, again, we're seeing a much higher number of patients actually survive these injuries and show up to see us for treatment that we weren't seeing in the past. Additionally, we're seeing much better hemorrhage control in the field. Surprisingly, pre-hospital tourniquets weren't really that common prior to 2009 due to concern for long-term nerve damage. However, due to a lot of research coming out of Iraq and Afghanistan suggesting improved survival with field-applied tourniquets, it's really started to come back more in vogue. So next, we're going to move on to discussing emergent management of mangled extremities. The number one thing to keep in mind with managing these patients is life before limb. As orthopedic surgeons, it's very easy to get distracted by what's going on with the extremity, but our first question should really be, is the patient stable? If the answer to that is no, then we control bleeding, we resuscitate as appropriate, and then down the line we can have more of a discussion of whether we should be pursuing fixation and salvage versus an amputation. One of the other very important things to keep in mind in emergent management of these patients is antibiotic administration. There's a large study that looked at type 3 open tibia fractures and found that administration of antibiotics after 66 minutes from injury was an independent predictor of infection by 90 days. So this is one of the number one things that we can do in the emergency department to really have a real impact on our patients' outcomes. So now moving on to the decision-making process when we're looking at these patients, whether we move towards an amputation or towards a salvage procedure. When I was thinking about this, my first question is there a scoring system that helps us make this decision? Unfortunately, the answer turned out to be not really. There are about 5 or 6 different scoring systems that have all attempted to predict whether a patient with a mangled extremity will end up with an amputation or a salvage procedure. And unfortunately, none of them have really been validated. There was a very large study looking at 556 lower extremity injuries. All 5 of the different injury severity scores were applied to each of those patients, and none of them were predictive of whether the patient received an amputation or not. Conversely, those patients that came in with good scores, though, the score somewhat was predictive of whether the patient was salvaged. However, that doesn't really help us with our question because those patients that come in with a baseline good status aren't really the ones that we're trying to make these really difficult decisions about. So unfortunately, where we're at right now, we just don't really have a good scoring system to help us out. So second, when we're evaluating whether to amputate or to salvage a patient, one of the major questions is, should tibial nerve injury or plantar sensation impact the decision? Historically, the answer for this was yes. But recently, out of data from the LEAP study, we found that the answer to this is resoundingly no. So as part of the LEAP data, 55 patients without plantar sensation and a mangled lower extremity were matched to a control group of patients with similar injuries who did have plantar sensation intact. Of those 55, 29 went on to salvage and 26 went on to an amputation. And at 2-year follow-up, there was no significant difference between the insensate group and the control group when we're comparing functional or psychosocial outcomes. Not only that, but those patients that initially presented without plantar sensation, that initial presentation was not at all predictive of what their long-term plantar sensation was. So while this used to be historically a really important thing to think about, I think this is this study has shown that we really should put this by the wayside, and that's really not part of our initial evaluation. Third question when we're deciding whether to amputate or move forward with a salvage procedure is, does the condition of the patient's ankle matter? Again, this is data coming out of the LEAP study, and the resounding answer to this is yes. They looked at 174 open hindfoot and ankle injuries. 116 of these went on to salvage, 58 went on to a below-knee amputation. And of those patients that were salvaged, those that either required an arthrodesis or a free flap to the ankle or the foot, had significantly worse functional and psychosocial outcomes at 2 years. And this was using the sickness impact profile, which looks at 12 different categories of function. So overall, I really like this algorithm, which was published by Credit based on the LEAP data. When a patient comes in, our first question should be, has there been ischemic time greater than 6 hours? If so, unfortunately, that sways us towards amputation. We then address the general injury of the patient, if they're hemodynamically unstable, if they're in severe shock, and then their overall general condition. Is this patient elderly? What's their baseline functional status? Do they have a lot of significant comorbidities? All of this really plays into how well they'd be able to rehab a salvage procedure. And then we also need to take into consideration the expected overall result. And this addresses the condition of the ankle, which we mentioned earlier. So if the patient is expected to have an arthrodesis of the ankle or a free flap, then maybe that would lead us more towards amputation due to their significantly lower outcome scores that we were addressing earlier. So overall, it's important to take into consideration the patient's medical condition, also the surgeon's experience, and of course the patient's wishes, but unfortunately in a lot of our situations that's not available due to patient condition. And then lastly, it's important to take into consideration our local medical system's capacity for rehabilitation or for complex postoperative treatment. So as an overview of decision-making, unfortunately, we don't have a good scoring system to help predict which patients will get amputation. Tibial nerve function really should not play a role in the decision to salvage versus amputate. Patients needing an ankle arthrodesis or a free flap really do poorly with salvage procedures. And then lastly, it's important to take patient, surgeon, and community factors into consideration. So we're going to move on now to definitive management of these injuries with the assumption that we're moving forward with a salvage procedure. The first goal is to irrigate and debride the injury, with debridement being the most important factor in this process. And then, of course, wash, and wash again. The flow study suggested that rates of reoperation were similar regardless of irrigation pressure. So it's fine to wash the injury with low flow, just as long as you make everything as clean as you possibly can. And then, of course, to repeat this process as necessary. And then moving on to definitive management. So we've stopped the bleeding. We've washed the wound. Next, we have to fix the bony issue, address any vascular issues and any soft tissue injuries. If there is a vascular injury, there will have to be a discussion with the vascular surgery team in terms of order of events, whether they do their vascular repair first or we move forward with our fixation. And then, of course, our fixation will depend on fracture characteristics, whether that consists of an external fixation, ORIF, or intramedullary device. After the fracture is provisionally fixed, it's important to address any compartment releases as indicated. And then, of course, looking at dead space management, applying wound vacs, potentially thinking about long-term wound coverage. So lastly, I'm going to move on to techniques for dealing with bone loss. We have techniques that our options include autografting, the Masquelet Technique, and distraction osteogenesis. In terms of autografting, this really is a gold standard because it has 3 of the characteristics that help with bone growth. Autograft is osteoconductive, meaning it serves as a scaffolding for new bone growth. Osteoinductive, meaning it contains all of the growth factors and cytokines that really help stimulate further growth. And then it's osteogenic. It contains its own osteoblastic cells. Cons of acute autografting is, of course, there's donor site morbidity. And then, unfortunately, it's limited to defects that are less than about 6 centimeters in size. So if we're looking at addressing larger defects, our next option would be the Masquelet Technique. This is done in 2 stages. First, our bony injury is debrided, and then a cement spacer is inserted into the defect. Then we wait approximately 4 to 6 weeks, and the cement spacer is removed. What remains around the spacer is an induced membrane, which is then filled with bone graft, and then the limb is stabilized until the bone graft heals and consolidates. The thing that's unique about the Masquelet technique is this induced membrane. There is a study that looked at the characteristics of this tissue and found that it was very highly vascularized, and this peaks at about 1 month after you insert that cement spacer. And it also has a great deal of expression of cytokines that really help with bone growth. VEGF, type 1, collagen, and IL-6, all of these, again, peak at about 1 month, which is why we remove that cement spacer at 1 month and bone graft at that time. This technique has been shown to successfully repair bony defects up to about 25 centimeters. So obvious pro is that it really helps to address significantly larger defects, and con is that it's a prolonged process. So you do have that gap between your initial cement spacer until you're bone grafting, and there again is donor site morbidity associated with bone grafting at your second stage. So overall, mangled extremities really are becoming more prevalent due to increased survivability. We touched briefly on emergent management, and really the decision to amputate versus salvage is complex, and you have to take into consideration multiple different characteristics of the patient, the surgeon, and the community. And then if the salvage is indeed chosen, there are multiple options for dealing with bone loss. So for that, I'm going to pass things off to Dr. Hagen. She's going to talk about that a little bit further. Thanks.
All right, well, good morning. Thank you, Sarah, great job, and it is absolutely fantastic to be back. Thank you, guys. It feels like it's been a long road, although it honestly hasn't been that long in the grand scheme of things. All right, so I'm just gonna continue along with where Sarah started. We're gonna talk a little bit about the soft tissue management, which is something that this department's different because of Dr. Hanel and the great hand service, but often places the orthopedic surgeons are not directly involved in the soft tissue management, so it's good to understand some of what the plastic surgeon and the hand surgeons are thinking about. We'll talk a little bit about distraction osteogenesis, specifically in this case, in the case of a mangled extremity, a little bit about amputations, and then I have a case I'd like to get to that kind of pulls all of this stuff together. So, timing of coverage. As far as we know, sooner is better, and that's been shown through multiple studies. The caveat with that is obviously it needs to be clean, so if you flap something that's dirty, it will pus out. How soon, depending on what you read, immediately, 3 days, 7 days. 7 days is kind of the thing that people have hung their hat on, and that actually is within the best practice guidelines of the American College of Surgeons. So they do recommend 7 days ideally for definitive coverage. There was a recent study that just came out to see how good we are in North America at this. It looked at over 140 trauma centers, and they made it binary. So did they get it within 7 days, or did they wait till 7 days after? And they did find that even after matching for things like complexity, AIS, ISS, that if you are after 7 days, you do have a much higher risk of major complications. Major complications being things that are important to us, like deep infection, osteomyelitis, and amputation. So the 7 days does seem to be a good turning point. But unfortunately, we also found that over half of the cases did not get covered within 7 days, even if they were immediately sent to the trauma center that was the definitive center. So 7 days is good. We're not quite good at getting to that benchmark yet. So some options. So local options. You guys hear about the gastroc soleus and reverse sural, which is kind of an exotic way of covering some wounds on the foot. Nice thing about this is, as you guys know, you're rotating on a pedicle, so you don't need to be a microvascular surgeon. So this is something that can be done by me. It can be done by someone who doesn't use a scope. So the nice thing about it is you leave it attached to its blood flow, and then you just rotate it to cover a defect. The downside, as you guys know, it has very limited size and limited coverage options. So historically, they said that the gastroc's good for the proximal third, soleus is good for the mid-third, and then the distal third of the tibia is really that kind of no-fly zone where you have to have free flaps. You can finesse it a little bit, but it is very limited by what you can do with it. And the thing that probably is more important, especially when you're talking about using a soleus flap, is it's getting deeper and deeper, meaning if you have a tibia fracture, it's getting closer and closer to the zone of injury. So if you have a very bad tibia fracture, oftentimes the blood flow, the pedicles to the soleus or the gastroc are disrupted, or the muscle is just so beat up that you really don't want to rotate it. So this is good for things like chronic draining wounds or covering total knees, but oftentimes this is not going to be your coverage of choice for a mangled extremity just because it is also damaged. Which leads us to the free tissue transfer. And this kind of falls into two major groups, and I am by no means an expert on this. So this is either the fasciocutaneous or the muscle. It's really interesting. If you read the literature, there's really two camps. There's the orthopedic surgeon camp and then the plastic surgeon camp. But if you read the plastics papers, they say there's no difference between these flaps. You can use any flap anywhere in the body and they're all going to do great. You might as well just do a fasciocutaneous. Now, if you start reading the orthopedic literature, everyone advocates for muscle, and there are some reasons behind it. So the ALT being the most common fasciocutaneous, and you guys should know these phrases, right? So basically there's a pedicle that goes to the fascia and the fat and then the skin. So they just take a little bit of everything above it. So the benefits of this, it's less bulky. There is less donor site morbidity, mostly because they're not taking a muscle unit. And then depending on who you talk to, it may or may not be more technically demanding. So the more seasoned plastic surgeons and hand surgeons can be very, very good at elevating these. Whereas a muscle is very robust. It gives you like a big, thick bit of tissue that you can put on these defects. It can be cosmetically less pleasing. It can be bulky and require its own skin graft. So like Sara was talking about flaps on the foot and the hind foot, you don't want to put a big chunk of muscle right on top of the foot because even though it atrophies with time, it still can be very difficult for people to ever get a shoe on because it's just a very bulky flap. On the orthopedic side, again, the people tend to advocate for them, just because you can beat them up a little bit more, and we do beat these up, especially if you're doing the Masquelet technique where you have to elevate the flap and get your membrane and then get your bone graft in. I mean, we're cutting right through a flap that someone just laid down. There was a paper that just came out last year that looked at the radiographic union of tibia fractures and if they had had a fasciocutaneous or a muscle on top, and they claim that the muscle actually led to a faster union rate. So again, it depends on whose literature you read. Either way, they, as you guys know, require advanced training and skill. They can be very demanding. And the other thing you have to take into consideration is the intensive postoperative period. So like Sara was alluding to, some of these people can't tolerate the dangle protocol. They can't tolerate the flap protocol. Some of these people have multiple things going on. So part of the decision of how you reconstruct it is, do you think they're actually going to be someone who could be a free flap candidate? So we'll talk a little bit about distraction osteogenesis. I saw your grant around schedule from the last couple of years, and it looks like you got a frame talk earlier. This is not a frame talk by any means. This is just kind of some basic considerations if this is something that you're going to have in your armamentarium. So you guys should be familiar with the idea of distraction osteogenesis or transport or the Elizaroff technique. And the basic idea of this is you cut bone in an area that's not injured, that has good blood flow to it. And if you slowly move it through the tissue, as the bone tries to heal behind it, you can close your defect by growing it above, right? So the two ends where the bones meet are called the docking site. The area where the new bone has formed is called the regenerate, just so you have the general terminology of it. The general principles from my perspective, so it's kind of interesting just that this heals by intramembranous ossification, which is kind of fascinating, so you don't get a big callus like you would through secondary bone healing. It just basically solidifies in the shape of the bone that you're trying to create. Again, you want to make your corticotomy in the healthy segment, which can be very difficult in a mangled extremity. There might not be a healthy segment, or it might be distal instead of proximal, so you kind of have to mess with it a little bit. In general, you want to pull it at about 1 millimeter a day in adults. Now, if you have a diabetic or a smoker or otherwise a poor host, sometimes you have to go a little bit more slowly because if you go too fast, you can break your regenerate or you can get a non-union up top because you're just pulling it too fast. So in general, it's about 1 millimeter a day. Studies have shown that you do want to bone graft your docking site because it can increase the rates of union, and that generally is the rate limiting step. Most of the times the patients train themselves to look at the x-rays of the regenerate and they get super excited when they see it ossified, but it's the docking site that generally takes the longest time to heal. And then as far as timing is, I generally tell people that you hold it, so there's two portions, right? So there's the moving portion, and then once you've filled the gap, then you hold everything. And roughly it's about twice as long as it took to do the transport, if you're just trying to estimate, because everyone wants to know how long the frame's gonna be on. So this is kind of a standard style frame for a lower extremity. The knee is to the left, the foot is to the right. It's at minimum 3 rings. Sometimes you put multiple rings or foot frames, but again, that's a little bit beyond the scope of this. But I always carry a picture of this in my phone to show the patient because this doesn't look like the X-fix they have on their leg when you're doing the staged debridement. This looks very different, both good and bad. So sometimes they have a hard time conceptualizing it. Most people know what a halo looks like. So I've started just telling them it's like a halo on your leg, and they get some rough idea of what it's supposed to look like. So this is what your regenerate will look like, and it's super, super wispy and very anxiety-inducing in the beginning. So on the left is the first x-ray after I've finished the transport, and you're like, I think I see a couple of cells in there. Like I see a little bit of calcium, and then it starts ossifying, and then it starts ossifying, and about 6 months to a year afterwards, you'll actually see that there actually gets a cortex, and then you're high-fiving. But for those first couple of months, you're like, yeah, I really hope there's something there. So the pros for it is that it's an extremely powerful tool. It's very good for large defects. If they have a limb length discrepancy, it's something you can correct with that, obviously. If they have a malunion or if there's some other deformity in the leg, it's something that can accommodate basically any anatomy that they have. It requires minimal bone graft, so not the huge amounts to fill the defects that you would need even in a Masquelet. The patient can walk in the frame. The frame is stable, so it's not like bone grafting a nail where you don't want them to walk on the nail for 6 months until you see the bone healing, and you can actually encourage them to walk in the frame. And one of the purported benefits, especially in the setting of infection, is that there's no metal at the fracture site. So once it's healed and you take everything off, then you don't always have this biologic membrane that you're worried about in the background. There are a lot of downsides, right? And that's why a lot of people don't do these. So you got to emotionally prepare them for 1 to 2 years in a frame, a minimum, right? So you just start with that in the conversation so they have a realistic expectation. They will all get pin site infections 100% of the time. All of my patients have a standing prescription for Bactrim that they fill if they start getting oozy. There's all the things that happen to the foot. The foot hates this, right? You get equinus, you get claw toes, they get stiff. Nobody likes, especially if you're lengthening them, no foot likes to be lengthened, so there are problems with that. It's very time intensive. You have to have a patient who's compliant, who is willing to turn the frame even though it causes them pain. And that's something difficult for them to wrap their minds around. And if they don't turn the frame, everything consolidates and then it's over. So that's a conversation. You have to do it to music, time it with your medications. You have to turn this frame even though it doesn't feel good. And people claim it's technically demanding. I mean, it is. It's no more demanding or no less demanding than doing a good nail Masquelet or a good plate Masquelet. It's just another technique that requires a little bit of extra thinking. So a few words on amputations. Does Dr. Smith still operate with you guys? Oh, that's a shame. Okay, most of what I learned about amputations came from him. So over almost 190,000 amputations are performed annually here. Only 16% of those are because of trauma, right? Most of these are because of diabetics and vascular paths. But of the people living with amputations, 45% of them are because of trauma, right? You guys learn that once you start amputating diabetics, it's kind of the slippery slope towards the end. So a lot of those people don't live very long with their amputations. They don't walk in a prosthetic. Completely different from the trauma population, right? You got an 18-year-old that crashed his motorcycle. He's going to walk with a prosthesis for the rest of his life, hopefully. So Sara talked a little bit about the LEAP project. It's kind of the one thing that we have to hang our hat on because it's the most extensive follow-up that we have. It was a prospective study back in the 90s looking at salvage versus amputation lower extremity. And every couple of years they do follow-up, so it's a really good clinical outcome study. And unfortunately, at the 7-year follow-up, it didn't answer the question of which is better. They both do about equally poor, unfortunately. Only about 34% of these people reach population norm, which is actually impressive. I'm surprised that they got that high. A little over half of them are working 7 years post-injury. And of the amputation group, about a 30% rehospitalization and 14% revision rate. So the big thing when you're having these conversations with your patients is it's not one and done. It may seem easy just to take it off, and sometimes it is, but that is not the end of the story for them. As Sara said, the scoring systems don't reliably predict outcome. And the thing that really was interesting that came out of the 7-year follow-up was that the lifetime cost of the amputation is 3 times higher. And that's something that you don't ever want money to come into the conversation, but a lot of times patients are hesitant to go down the salvage route because they're worried about the hospital bill. Like, I can't be in the hospital for the next month and have 5 more surgeries. And that's true, and it's incredibly expensive, but if you looked at the lifetime of the amputation, that actually can be higher depending on how young they are. So some basic stuff on amputation. So amputation level matters a ton. So this is some historical data looking at the oxygen costs. So the y-axis is how much oxygen they burn in order to walk. The x-axis is the amputation level, and normal is all the way to the side. So TT is transtibial, so that's below knee. TF is transfemoral, so that's above knee. So there's a huge step up of oxygen consumption if you walk with above knee amputation versus a below knee. Same with speed. So this is the reverse. Normal is on the right. So, and this kind of makes sense if you've ever seen anyone walk with a prosthesis. If you have an above knee prosthesis, you walk much more slowly than someone who has a below knee prosthesis. So level matters, and the thing that actually matters is the knee. So the knee motion, being able to control your own knee, regardless of how fancy your prosthetic is, minimizes how much your body hikes itself up as you clear your foot to walk. So if you can maintain the knee, it actually affects everything. So this is a quick study looking at bilateral, which is just horribly traumatic. So the top one is bilateral below knee, the bottom one is bilateral above knee. Obviously the speed is going to be very different, the oxygen consumption is very different. And this used to be on the OIDI, and it just blows my mind. So it's better, not better, you walk faster and use less energy if you have bilateral below knee amputations versus just having one above knee. So this comes into the conversation if you have something that could be a below knee amputation but also has a crushed knee. Sometimes it's worth reconstructing a knee even if it's not a perfect knee just to save them their own knee versus converting them to an above knee amputation. So level does matter a lot. Again, these prostheses are incredibly expensive. Just for the lower extremity, it can be anywhere from $3,000. I don't think you can actually get one for $3,000, upwards of 100,000. And these are not the carbon fiber ones that you guys see the Olympians riding on the track, right? This is the basic prosthesis. Lifetime estimate on an amputation is around 600,000. And the problem is, and it's getting worse, many insurance companies cap how much they will spend. And some of them even will only buy them one prosthetic for their entire life. So you can imagine if you're 18 and you get a below knee amputation, you get big, you get small, your prosthesis has to change. A lot of times they just don't have the wherewithal in order to get it. So again, it's not one and done. It's not the easy way out, which sometimes it can get pictured as. So quick case, actually not a quick case. And just as a forewarning, this case is not completed. She's not done yet. So there's still a lot of things that could happen. So this was a 7-year-old who was riding an ATV down the road. She got hit by a car. She was unhelmeted. She has a crush to her left lower extremity, and when she comes in, it's pulseless, even though there's not a tourniquet on. And then she has some skull base fractures. She's got a small subarachnoid. She's intubated. She's stable, but critical. So this is what her tibia x-ray looks like. So obviously she's got a segmental tibia, or a large segmental defect in her tibia with a segmental fracture of her fibula. And then this is your trauma bay picture of the leg, all right? Obviously there's going to be very extensive injury to this patient's leg. So she gets a CTA. It demonstrates 3 vessel disruption at the level of the fracture, but there is a little bit of distal reconstitution. So either one of the vessels or some of the vessels are in spasm, or she's just being perfused by her collaterals. Our vascular surgeons decide that she is too sick to bypass. They refuse to bypass her. So regardless, we take her to the operating room to wash it, debride it, and stabilize it. She has a huge segmental defect in her tibial nerve. So getting back a little bit to what Sarah's saying, probably more extreme. So she's missing 10 centimeters of her tibial nerve. She's missing 10 centimeters of her posterior tib artery. Get the X-fix on, warm everything up. She has some cap refill. It's sluggish, but it's present, okay? So this starts the conversation with family. She's only 7, she's intubated. All right, so this is as she gets washed, she gets debrided, she gets washed, she gets debrided. This is what she looks like in her X-fix. She's got roughly a 10 centimeter defect. Family says, I don't care, we want to save it. We got to save her leg. You can't take her leg off, she's only 7. Okay, understandable. So what are your options, right? She's skeletally mature. You can't do a nail. So you can still Masquelet, plate it, put a big cement spacer in there, go back and get bone graft later. That's a lot of bone graft to get out of a kid, right? You can't do any RIA, you can't do any intramedullary stuff. You can take some stuff from the pelvis, but that's a lot of bone graft to take. You put her in a transport frame and regrow it. That's definitely possible because her physes are still attacked above and below. Someone threw around the idea of a vascularized fibula. Well, why don't we take a vascularized fibula and plug in here? You can. The problem is she's basically a no vessel leg. So through all of this, she still has a DP. So, but other than that, there's not a lot of vessels that you can borrow from. And you can always go back to amputation. So these top three, regardless, she's going to need a free flap on a leg that already has some vascular compromise to it. So we decided, okay, let's flap her and cover her first, see if she survives that, see if the leg, as long as the foot doesn't die after the free flap, then we can go from there. So she gets flapped. They do muscle, which I'm a fan of. So she's got she does a latissimus. They do a latissimus flap to her. They cable graft her tibial nerve. So they put a big graft in her tibial nerve. And then they also, which blows my mind, also then flapped around the tibial nerve and the vessel in order to reconstitute it, and then reconstituted the distal posterior tib. So she gets a very complex reconstruction of her leg. And then we wait. So I had decided I was going to do transport because I didn't want to steal enough bone from her, both of her sides of her pelvis. So the problem with putting the transport frame is that flap has to be rock solid before that frame goes on. I mean, you have to be able to scrub it and get it as clean as possible, and they can't touch it once the frame goes on. So it's got to be pretty rock solid. So we waited and we waited and we waited and we waited. And then 8 weeks after she gets her flap, it was enough that I could actually put her transport frame on. So lots of things going in here, again, beyond the whole scope of this. You have to avoid all of her previous X-fix pins. You have to avoid her flap, which is more than half her leg. Also trying to avoid her physes, right? So that limits your proximal and distal fixation of your X-fix pins. So here's up by her knee, stopping short of her physes. Down by her ankle, I basically only have one pin in her distal tibia, and then I put everything else in the foot just to try and not tether or shut down the remaining growth. So I started her early because she was a kid. I thought she was going to heal. Even though I started at 4 days, nothing moves. So she's turning it for a week. She said, yeah, I'm turning it. Nothing moves. Sometimes you have to go back in and re-break it. Luckily for her, we just turned on the iPhone and I cranked on her frame and heard a pop, and it moved and it was good, and I didn't rip out her pins. So I just sped her up a little bit, so a little bit faster than I would normally. If she hears she's going 1.25 instead of 1 a day, just because she's so young, right? They're new, she's going to heal in really fast. Here she is now. So she turns the frame herself, she cleans it herself, she's fantastic. She's the best patient I have. She's moving her toes, she has some pressure sensation in her foot. This is as of 2 weeks ago. So she's actually got some pretty legitimate regenerate, again, because she's little, so you can see some wispies. It's still not amazing. All right, so here we've made almost 6 centimeters. We're over halfway there. So now I'm at the point of the now what? All right, and I'll open for questions for the faculty because I'm really curious. I see Dr. Schmalley here and some of the pediatric faculty. So she's in a frame that I can lengthen her. Her other leg has been growing because she's only 7. So should I also lengthen her to match her other leg? Should I over lengthen it? I don't know if she's got physeal arrest. I don't know if this leg is going to grow after the frame comes off. What happens if I lengthen a cable graft and a vessel repair that just got done? So these things I still haven't completely come to terms with on what I'm going to do with that. I'm going to bone graft her docking site, so I'm going to have to dig into her pelvis a little bit, but I won't need to take as much. And then I'm also debating whether or not I want to plate her just to support this whole thing, because as soon as I tell her to run, she's going to run. So she's a kid. So just quick looking forward, things where we're going next. So the outlet trial is leading off of that ankle study that came out of the LEAP. You know, even though the LEAP shows that there's no difference between the two, people still think that there probably is, right? We know that the crushed feet do poorly. So this is going to be a trial going forward just to see if we can delineate a little bit more if there is actually a patient population that does better with amputation. The answer is going to have to come in the biologics. We can only harvest so much from the body, and if they're a C-type host, their bone graft is not great, right? So it's going to have to come from the lab somewhere, either through something like placenta or growth factors beyond just BMP2 and BMP7. And then the big elephant in the room is the psychosocial interventions. These people aren't normal when they're done. This is a horrible thing to go through regardless which way they go. And the mental health, as we know from multiple studies, matters more than what their x-rays look like at the end. And this is the one thing we don't have any funding in, is how to actually get these people right emotionally and mentally when they've been through something horrible like this. So as Sara said, save the life. We get excited about the leg, but it only survives if they survive. Preserve the function. If you can save the limb, do it. If not, save them a good level that they can walk with. And manage your expectations from the beginning, because this is a difficult thing for people to go through. Great. Thank you very much. Dr. Schmalley, should I lengthen her?
That was quite a case. I would probably see how she does with all the work that's happened before taking the risk of lengthening to all the reconstructive
Yeah.
soft tissues. So
Yeah.
do you suspect an injury to the physis on either the proximal or distal end of the limb?
Well, so her distal physis is tethered right now, so there's going to be no growth at this point because of the frame. Proximally, it's too soon for me to tell. It's only been about 3 to 4 months. Her dad, her family's kind of on board with this. Her dad's really, he keeps saying every time I see him, "You're going to make her match the other side. Can you make her match the other side?" And I'm like, well, no, maybe we'll see. We'll see. We'll see how we go through here. But yeah, no, I mean, I don't know about stretching out those vessels. I mean, she's 8 now, so she's. If it were me, if it were my body, I would not lengthen it. But I don't know. We'll see. Dr. Hannell.
Hey, Jen.
Hi.
Welcome back.
Thank you.
I think it's comfortable and you should be comfortable taking and lengthening through your vessels and vessel repairs and through a flap.
Okay.
And both, whether or not you choose to do fasciocutaneous or muscle, you can drive pins through that and they will go through that.
Oh, I do.
The question that I have, why won't you lengthen her twice? Get her to heal.
Mm-hmm.
Come back 2-3 years later if she has a deficit and put her through it again. I think that if you're going to err, I would err to neutral length and then
Match it to the side as
Yeah.
it. I mean, you're always catching up, right? Once I consolidated, but okay, good.
I think so. Thank
Good.
you.
I will. I'll let you know how it goes.
Yeah, thank you both. That was really good. So Jen, can you tell us a little bit about your R21? It sounds like you have a nice combination of basic research that fits with your clinical practice.
Yeah, absolutely. So I got lucky to be paired, or I met one of our biomedical engineers a couple of years ago, and he's a Kiwi, and he's from New Zealand. He is a tissue engineer and has spent his whole career working on the vascular side. So he's been working with our cardiovascular surgeons to regenerate vessels. And basically what he's found out is, so he takes placenta and then he grinds them all down and then takes the entire cascade of cytokines that are on it, both on the maternal and the fetal side, and then puts it on a matrix. Basically, similar to if you guys ever use BMP2, it's a liquid form, and then you squirt it on a collagen matrix. And then he's been using this to regenerate vessels. And what he's found is it has an amazing angiogenic potential, like way above any of the just VEGF or any of the other things that are out on the market. So he had been putting it in rats, and even within about 5 days, he puts it in their skin, and they form a fully mature capillary complex, which is really impressive without getting fibrosed over. So he hadn't been using it in bone because he's a vascular guy. So I met him, started trying to encourage him. So, I was like, well, this could be something where we could generate a membrane and not have to do Masquelet, just create a membrane. Or if it really does have this full cascade, it might be as osteogenic and osteoinductive, if not more, than BMP2 or BMP7. So we were supposed to have a meeting this morning. We have some of the prelim results. We have R21 looking at putting it in a rat cranial model first, because that's a little bit easier to do. And then I actually want to make segmental defects in femurs and put little rats in X-fixes and then fill it in. And basically, right now, we're just trying to show that it's as good as BMP2. And based on the results so far, it looks pretty good. So the nice thing about it is it's not stem cell research with all of the bad press that comes with that. So there is no living cell in this. So there's nothing to be rejected. Right, it's just the cytokines. It comes at the termination of pregnancy, so there's no question of fetal tissue or anything like that. And there's placentas everywhere. So, they're constantly being produced. So I think this stuff takes a really long time to get this research up and going, but so far it's been pretty encouraging. Now, it's on the market, and you guys have probably seen ads for placental tissue. And all of the research, unfortunately, so far has been done by industry. And they'll show you pictures of diabetic feet where they've injected in a toe and the person regrew a foot, right? Like some of this stuff is just absurd. But I'm hoping to do a little bit more rigorous science and maybe get to the point where we could do a clinical trial with it, because I think it, you know, and this is not just obviously this me, just doing one growth factor is laughable when you look at how complex the healing actually is for bone. So it's kind of a cool thing. It's still very early, but I think it would be really cool. So Sarah, I have a question for you. I get asked this all the time. What do you want? Do you want an amputation or do you want to be saved?
I think I'd depend on where I am in life. Like if my age right now, I'd want to be saved. But
Yeah.
just give it a shot and see what the outcomes is. But if I were older and not walking as much, then I'd probably go for an amputation.
Yeah, I know. I think it's a curious question, and I ask myself that every couple of times. You know, I think honestly, and God willing, I don't get run over as I walk out, and you guys don't put this in writing. I think probably at this point, I would probably go for an amputation simply because I could get up and get back to work sooner. And the problem is, the older you are when you get amputated, the harder it is to walk in a prosthesis. Right, we've all seen, and the problem, you know, you've seen all those pictures of those guys running, guys and gals running with those carbon fiber, right? That's G.I. Joe. Those people were the healthiest, most disciplined human beings on the planet right before the IED went off. Of course they're going to do well. They do well with everything because they have all the resources and the motivation and everything behind it. They're not the guy standing on the street corner smoking that gets hit by a bus, right? Those people just don't do the same. So the military data on the amputations skews it towards making it look much better than it can be translated to the civilian population. So the older you are when you get one, sometimes the harder it is to get up with a prosthetic. So I don't know. I don't know what I would want.
Any other questions?
Dr. Chestnut?
Well, how about,
Dr. Hanel. Sorry, Al.
if you go back to Ted Hansen, and you look at what he did when he looked at reconstruction of open tibias, and he said, you know, you take somebody and if you can't get them into a functional limb in 2 years, you've destroyed their lives, predictably. And I think there's a big difference between our 7-year-old
Yeah,
and our 27-year-old.
absolutely.
And so I think that's one of the things that we keep driving. And so that people ask the question, who does better, the salvaged limb or the amputated limb? It really is. It really is individual. And I think the reason that we're not finding that difference is because we haven't asked the right question. I don't know what the right question is, but I think it really needs to be set up into a series of where are we going with this extremity and this patient.
Right. And just because we can, is it actually the right thing to do, right? And you can be on a perfect path, even with a motivated person with resilience, and then they get infected. Well, now that 2-year mark looks a little different. So, I agree.
And I did like the fact that you did reinforce the fact that the psychosocial implications of limb salvage are as much a determining factor as anything.
Yeah, and that's the thing we don't have a fix for.
Again, thank you.
Thank you.
We have a ringer in the room.
A plant.
I have a little familial bias here on a number of levels. In terms of osteogenesis, do any of the osteoporotic drugs, and I'm thinking of the ones that have been shown to increase bone density, whether Forteo, Amgen's denosumab, any of these have any place in addition to the antibiotics or anything in terms of maybe helping with the osteogenesis of these bones?
Yeah, no, that's a great question. And you do have bias just because your father got a lot of those on the map. I think the short answer is we don't know. Forteo probably will be the better one just because it actually directly stimulates the bone healing. All of the other ones, even the denosumabs, the bisphosphonates, they work by tipping the scale the other way, right? They break down, they stop the breakdown, which then artificially makes it look like you're increasing the build up. It probably also depends on how we're healing, right? So if we're doing bone grafting where it has a callus, a cartilaginous analog that then gets broken down to turn into bone, we probably don't want to shift. We don't want to put them on bisphosphonates because they're not. It's breaking part of that cascade. So I do have a couple patients with non-unions that I have tried to advocate to get on Forteo just because I've tried everything else. Problem is it's very expensive. And it's very difficult for the patient to take because they're injections and it's a daily injection. So yes, I think it's probably good. I worry about any type of systemic shifting in someone who already is catabolic, because usually this is a polytrauma situation.
Yeah, I would certainly think not putting them on Fosamax or Actonel or anything of the bisphosphonates would be the case. However, the ones that have been shown to increase, have some increase in density, whether Forteo or denosumab or something, I just am curious if that would actually be beneficial in this case, to just stimulate growth, show increased density, or if nothing else, to stabilize at a harder level. And I'm curious if that's part of the regimen.
It might be, and again, the bone density is it's a point of contention between the orthopods and the metabolic bone disease guys, right? Because you guys like bone densities because it makes it look like it's harder, which is great, but it doesn't mean that the quality is as good, right? It can be more brittle.
Right.
So just because the bone density is up doesn't mean it's necessarily better. And
It's a different type of bone.
Yeah, it is. Yeah, it's a different marker. But no, I mean, Forteo, I haven't done Forteo on anyone that's been in a frame. Some people also inject the regenerates with cocktails of cytokines and things like that to try and stimulate it. I mean, I'm kind of just throwing a bunch of crap at the wall right now just to see what sticks. But something like that probably has a role, yeah, for sure.
Anyone else? Thank you.
Thank you, guys.